have some Plicker questions that I put together for both the first and the second. So usually about 10 of them, and so we can do that at the end. So anyway, so here we go. So we're going to talk mainly today about COPD as well as lung cancer at the end. So of course the COPD has a lot to do with smoking, and that'll get kind of obvious as we move on. All right, so here we are for COPD. So, well, what is COPD? You know, I always like to start with, well, what is it? And so when you're making your grid, so it's an airflow limitation. It's not fully reversible. So, and then by that, it means that these people can get air in, but they usually can't get air out. So it's progressive. It gets worse and worse as it goes along. There's an abnormal inflammatory response. So by that, we mean this is what happens that a lot of times the lungs become inflamed. The inflammatory response takes over, and that's how you end up getting more and more problems with it, primarily caused by, again, cigarette smoking and other noxious particles or gases. Third leading cause of death in the United States, so kills more than 133,000 Americans every year. So that's more than flu and more than coronavirus so far. So hopefully that stays that way. So what are some of the risk factors for these COPD patients? Well, number one, first and foremost, is cigarette smoking. Anytime I'm getting a report on a patient and they tell me, you know, hey, they got COPD, if I don't ask the question, it's in my head, are they a smoker or are they a recent smoker? Maybe they quit when they got admitted. So other thing is occupational chemicals and dust, whatever they're doing for a living. Yeah, it might be I always think of mine workers when I'm thinking of that. Air pollution. Some big cities have a lot of air pollution in them. This has been really a big deal over in China, but it of course happens here as well. Severe recurring respiratory infections. A lot of times those are going on from childhood. So that kind of predisposes somebody to get that. That alpha-1 antitrypsin deficiency. So that's a hereditary thing. An increase in proteases, and that's an enzyme that kind of breaks down proteins. And what it ends up doing is it causes lung damage. So anytime we see that, someone that doesn't have any of the other risk factors and they suddenly develop COPD, that's one of the first things we look at, is that alpha-1 antitrypsin deficiency. The other thing is a low socioeconomic status. Tends to be these are people that don't have as much access to health care. Maybe they're not taking as good a care of themselves as maybe they should, just because they lack the education that they just haven't been informed. So they kind of tend to be with the smokers too. So again, COPD and smoking. So clinically significant airway obstruction. So it develops in 15% of smokers. I'm sorry, I kind of cut off. So while I'm thinking about this, I'm going to repost this whole PowerPoint slides so that you can kind of see them. And maybe if you want to go through it without having to look at the pictures that I'm doing. So again, we consider COPD as a diagnosis for anybody, and anybody that's got with a history of that's over 40, with a history of 10 or more pack years, or after 20 pack years. So, and you remember how to calculate the pack years. So that's the number of packs of smoked per day for how many years. So someone that smoked for a pack a day for 10 years would have a 10-year pack year. Somebody who smoked a pack and a half for 10 years would have a 15. So I hope that makes sense. So what goes on with cigarette smoking? So, well, nicotine, it stimulates the sympathetic nervous system, right? And that decreases the amount of functional hemoglobin that's in the body. It also increases platelet aggregation, and it compounds any problems that you might have from coronary artery disease. I hope my paper shuffle is not throwing anybody off. So COPD is smoking, the effects on the respiratory tract. So you get that hyperplasia of goblet cells. The goblet, by hyperplasia, as you know, that means they get larger, right? They start working, and that makes them work better. You also get a loss or a decrease in your ciliary activity. So That's that ciliary elevator mechanism that, the fingers that are in those cilia that are kind of helping keep mucus kind of pulled up and it comes up into your mouth. You hopefully cough it up and spit it out. And that's the way that works. And smoking kind of tends to interfere with that. You get an abnormal distal dilation and destruction of the alveoli. We'll probably talk about that in a minute. But the alveoli, of course, that's the gas exchange unit there right next to the capillary bed. You get chronic enhanced inflammation, carbon monoxide, and that decreases the oxygen carrying capacity. Your hemoglobin likes carbon monoxide better than it likes oxygen, so it has an increase in that. So you also get an increase in heart rate and an impaired psychomotor performance and judgment. So passive smoking, environmental and secondhand, and those are the same thing. So those two different ways of referring to it, and they're just as bad. Passive smoking is just almost as bad. I want to say it's probably 90% as bad as primary smoking. Again, it decreases the pulmonary function, increases the respiratory symptoms that it might have, especially for in children, and increases the risk of lung and nasal sinus cancers, which we'll talk about at the end. So the occupational and environmental risk factors. So COPD, of course, develops an intense or prolonged exposure to, again, I'm talking about dust, vapors, irritants, fumes. So think about that maybe at work or something like that. Maybe, again, I always think about mine workers for that, but there are other jobs where there, a lot of manufacturing jobs might be subjected to that. High levels of air pollution. Some people might think, well, why don't they just move? Well, a lot of people just can't move. It's just not an option for them. So, and they've got to earn money. So a lot of times these jobs, especially coal miners, probably have this a lot more than anybody else. The other thing is you see is fumes from indoor heating or cooking with fossil fuels. And by that, I mean the loss of either coal for heating or for cooking. And this is the reason it tends to affect more women than men, because they're the ones that are stuck in the huts. And they're using coal or even cow manure. Dung is a good source of, it's a fuel. And so they might be using that to heat their home or to cook food. So recurring infections impair your normal defense mechanisms, especially those with HIV or tuberculosis, which we talked about the other week. So especially those that have those severe recurring infections in childhood, that's associated with just a reduction in lung function. So COPD and aging. So aging is just not, it's not for the weak, right? It's happening, right, to all of us. Hopefully that's happening to all of us. So it's also in their basic respiratory function, it kind of just starts to affect it. So as we age, we get a gradual loss of that elastic recoil of the lungs. So, they don't expand as well, they don't contract as well. Chest wall gets a little stiffer. Gas exchange alteration happens. Again, those alveoli, they've been working for however many years, however many decades. You get a decrease in your exercise, a decrease in exercise, it should say tolerance. So, sorry about that. The lungs become rounder and smaller, and that's just part of the aging process. The number of functional alveoli gets less, and those peripheral airways start losing their supporting tissues. Those are the ones that are 2 millimeters or smaller in diameter. So we're getting down into the smaller areas of the lung. So the pathophysiology of COPD is fairly complex. So COPD is basically a chronic inflammation of the airways, all right? Again, not fully reversible airflow limitations, and that's during forced exhalation. That's due to that loss of elastic recoil or airflow obstruction due to either mucus hypersecretion, mucosal edema, or maybe even bronchospasm. We talked about bronchospasm. We were talking about with, cold air or certain perfumes or something like that, some other thing that's all of a sudden has caused that. So the primary process, again, is inflammation. So that inhalation of noxious particles, gases, mediators are released. So what are the mediators are we talking about? They cause damage to the lung tissue. That's the neutrophils, the macrophages, and the lymphocytes. They're trying to do a good thing, but sometimes they do too much of a good thing. So airways become inflamed, and the parenchyma, it gets destroyed. Remember the parenchyma? That's just the functional part of an organ. So, so now we have along with the physiology, the supporting structures of the lung become destroyed. So that means the air can go in easily, but then it can't get it back out again. And that's why you see that barrel-chested thing for this gentleman here. So air gets in, and it just, they can't fully express all the air. So patient tries to breathe in, but the lungs are already in a hyperinflated state. So they appear like they're dyspneic, like they're not getting enough air. And actually the problem is there's too much air, right? So again, they look dyspneic, their exercise capacity gets decreased. The bronchioles tend to collapse down inside. That's due to pressure changes, and they get that barrel chest appearance. So you see a wide AP diameter in these folks. So again, some of the common characteristics, and don't get too hung up on bronchitis or emphysema. Those are things that used to be exclusively associated with COPD, but you can now, it's been determined you can have one and not the other, and that hopefully maybe becomes clear as we go through this. But one of the things is not everybody has sputum production, right? They may not have this mucus hypersecretion. A lot do, but that's not always the case. When you do have that, you have an increase in the number of mucus secreting goblet cells. Those are the things that are producing that mucus that kind of helps us keep our airways clearer and help trap bacteria and other things, that dust and stuff that are kind of getting in there, so that they don't make it all the way into the sterile portion of the lungs. So you get a dysfunction of the cilia. Remember, those are the things that are kind of helping the mucus get moved up and kind of get up and get out. Again, that hyperinflation of the lungs, you'll see that in those AP diameter increases, and that's barrel chested, and then you have gas exchange abnormalities. So COPD is systemic, right? It's a result of a chronic inflammation. It often coexists with cardiovascular disease, and we'll talk about that when we talk about the complications. But you get pulmonary vascular changes, and this is almost kind of in order, right? So you get small pulmonary arteries vasoconstrict. Well, why do they do that? Well, because the alveoli are getting less oxygen, so your body just naturally starts to shunt the blood flow away from the ones that aren't exchanging gas to the ones that are. So some of them start to vasoconstrict. Blood vessels may tend to thicken with that advanced disease. The pressure in the pulmonary circulation increases, so you start getting pulmonary hypertension, and that's how that ends up there. So some of the clinical manifestations, they tend to develop slowly. Remember, this is a chronic disease that kind of comes on slow. We always consider COPD as a diagnosis when someone's got a chronic cough or sputum production, they're dyspneic, or maybe their exposure to those risk factors. Dyspnea is usually what makes people come to the hospital. The two main things that I think most times people go to the hospital for are either a pain that won't go away and is becoming out of control, or the other thing is they can't breathe, right? So those are the things that kind of bring people more often. So dyspnea is usually what gets them started in here in a COPD case. So it's progressive and presents daily. What usually tends to happen is, because it is progressive, patients tend to ignore and rationalize those symptoms. They go, oh, I'm just, again, like I've written everything on here for you just because I want to make sure it's clear. But you might chalk it up to, hey, I'm getting old, right? Or I need to exercise more. I'm just getting out of shape. When actually it's COPD that is starting to get worse and worse. Eventually COPD starts to interfere with their activities of daily life. When they used to be able to move around fairly easily, and they find out that they're getting winded just walking to the mailbox and checking the mail or something like that. It occurs with exertion in the early stages, but in the later stages, they end up having difficulty breathing no matter what they're doing, right? And so that's what I mean when I say it's present at rest with the advanced disease. So the worse it gets, the worse they have trouble breathing no matter what they're doing. So what happens is it causes chest breathing. Chest breathing is that's the use of accessory or intercostal muscles. You've always seen people where they're really struggling to breathe and they're using their chest. They're really huffing and puffing, right? And that's not as effective a breathing method as abdominal breathing. Maybe experiencing or wheezing or chest tightness. They're characteristically underweight with anorexia, but the other thing is, when you have the COPD and you have really bad breathing difficulties, you can either breathe or you can eat. And so we'll talk about more in a second, but you tend to not eat as much just because you can't chew food and swallow food while you're not able to breathe. So they get that chronic fatigue, right? They're always tired. They just don't have any energy. There are some cases where that paroxysmal coughing, when the paroxysmal means that comes and goes, it can be so severe that they either faint or they actually can break ribs. So that's pretty hard coughing. So on physical exam, you'll find a prolonged expiratory phase. So with the inspiratory expiratory phases, it's usually 1 to 2 or 1 to 3. So that means you inhale for 1 second and you exhale for 2 or even 3 seconds. So that's the normal. These people will have a prolonged, right? So if you just kind of work with it yourself, taking a nice deep breath, as you kind of pay attention to your own breathing, you'll see where your IE ratio is. A lot of times there's wheezes, inspiratory and expiratory, maybe a decrease in their breath sounds, especially down in the lower lobes. That increase in that AP diameter, that's where they have that barrel chested. And tripod position is something people just naturally assume. They don't even realize they're doing it. Now, some people don't. We have to teach it to them. But other times, people just realize that on their own that they can breathe easier. So you can see this gentleman here. He's either sitting in a chair, leaning forward with his arms on his knees. This gentleman we do this all the time, and maybe in a regular, not in the ICU necessarily, but you have them sit and put the bedside table there with a pillow over and have them lean over it. You'll see these people in the grocery store, and you can see them leaning over their shopping cart. They're kind of almost bent over, and their arms are folded over the handlebars. So the other thing is they either do know or we have to teach them that pursed lip breathing. So, and we'll talk about that in a little bit. So some of the other clinical manifestations, that polycythemia and cyanosis. So hypoxemia that's just simply a decrease in the oxygen in the bloodstream. And of course, that's conversely has an increase in the carbon dioxide that builds up. So they almost have an inverse relationship. So what happens usually is the body is trying to respond to this loss of oxygenated blood flow. So what it does is it increases the production of red blood cells. So you can only do so much breathing. There's only so much gas exchange that happens. So of course it makes more red blood cells. So people tend to get that bluish red color to their skin. Very often these people will have hemoglobin concentrations that may reach 20 grams per deciliter or even higher than that. So these people get respiratory acidosis and they then become cyanotic. So what are some of the diagnostic studies? Well, a good HMP, you can find out what's been going on with them, talking about what happened in their childhood. Did they have a lot of respiratory infections that have been happening to them? Maybe we do a chest x-ray. That's one of the first things that they'll do. So get a chest x-ray, take a look and see what's going on. Not necessarily diagnostic, but it will show a flattened diaphragm. The diaphragm, that's the thing that helps us breathe, right? As the diaphragm contracts, it lowers the air pressure inside the lungs, so it's lower than the air outside the lungs, and so air rushes in. And then when it relaxes, it raises the pressure inside the lungs so that it's higher than the air around it, and that, of course, forces air back out again. This is the mechanism of breathing. You probably learned that in A&P. They'll do like a 6-minute walk test. 6-minute walk test is just basically how far can someone comfortably walk in 6 minutes. They actually take people out and just kind of walk them around. So usually between 1,500 to 2,500 feet is what most people can do. It could be a little more, a little less, just kind of depending on the person. Then we also do spirometry. You've heard of incentive spirometry. Well, spirometry, it's a measure of the volume and or the speed of inhalation and exhalation. So it confirms the presence of maybe of an airflow reduction, right? So we talk about the FEV1 FVC rate ratio less than 70 is one of the hallmarks of COPD, and I'll go into those in the next couple of slides here. So FVC is that forced vital capacity. That's the maximum amount of air someone can get out in a single breath. So they have to take a deep breath and have them blow, and they measure it, right? The other thing is the forced expiratory volume in 1 second. So the first second of air out in a single breath. This is what respiratory therapists do. You're never going to have to do that, nor are you ever going to have to calculate how that ratio is. But I want you to understand how it's calculated. So in COPD, both the FVC and the FEV1 are reduced, but the FEV1 is reduced. Usually it's more. So here's how it's calculated. So a normal FEV1 to FVC ratio. So most people have a forced vital capacity of 1 liter, and FEV, or a forced expiratory volume in 1 second, of 4 liters. So 4 divided by 5, so you've got an 80% ratio, right? And this is normal. Some people might be a little bit higher, but that's usually about the number. So with COPD patients, they've got an FEV to FVC ratio. Maybe they've got a forced vital capacity that's reduced, right? They can only get 4 liters of air out in that single breath, and their FEV1 is only 2 liters. So again, 4 divided by 2, now that's 50%. And typically, if we see something, remember the previous slide, if it's less than 70, that's kind of the hallmark of COPD. So this is the classification. So where they're going to use the GOLD initiative, the GOLD initiative for COPD, where what they're doing is they classify it mild, moderate, severe, or even very severe. And what they do is they look at that FEV greater than or equal to 80% of what's predicted. So the predicted number, that comes based on your height, your weight, and your race, right? So there's a whole grid that kind of talks about it. So depending on what it is, of course, the lower it is, then the more severe it is. Again, you're never going to have to calculate that, but just be aware that for COPD, there are different classifications for each one. So COPD, what are some of the complications that happen with COPD? So you can get cor pulmonale, there's exacerbations of COPD, acute respiratory failure, and then along with depression and anxiety. And we'll go through each one here in the next few slides. So cor pulmonale is probably one of the more critical ones. So this basically a hypertrophy or dilation of the right side of the heart, right? And that's the result of pulmonary hypertension. And you get pulmonary hypertension just because of the backflow of blood into the right side of the heart. Remember, the right side of the heart is trying to supply blood to the lungs. So you get an enlargement and a failure of that right ventricle due to that increased vascular resistance because of that high blood pressure that's in the lungs because of that pulmonary hypertension. This is a later manifestation of COPD, but still very critical. And eventually it causes the right side of the heart to fail. And maybe Stacy talked about this, but you'll definitely hear about that in the fourth. Usually once one side of the heart fails, the other side as soon follows. So what are those clinical manifestations you might see? Well, they're dyspneic, right? They're having trouble breathing, and possibly there's going to be lung crackles, and that's because of that fluid that's built up. But dyspnea, the most common symptom of chronic cor pulmonale. Lung sounds might be normal, right? But oftentimes there are crackles in the bases. You remember about JVD? Sorry, I had to take a sip. All right, so you remember about JVD, that jugular venous distension. Again, this is all happening. That fluid is backing up, right? Fluid is backing up out in the body. You get hepatomegaly with that right upper quadrant tenderness. So that hepatomegaly, right, that's the liver's enlarged. Again, it's all due to that hypertension or that pulmonary hypertension, excuse me. Peripheral edema, that kind of makes sense too, I'm thinking. So, and then of course weight gain, and that really is all about fluid. So that pulmonary hypertension, because you're having an increase in the right side's having trouble, so you're going to have less blood that's going to the left side of the heart. So you get a decrease in the left ventricular output. Well, that decreases circulatory volume, right? So what does your body do with that? Well, it activates the RAS system, right? So that makes it, and that tells your body to, hey, retain fluid, right? Because it thinks it's low on volume when actually it already has too much volume. So it's kind of exacerbating that problem. So how's that thing diagnosed? Well, they look at a chest x-ray. Part of it is, you're looking maybe for an enlarged heart or maybe a diaphragm that's been flattened out. They can do a right-sided cardiac catheterization, and that's kind of the gold standard, right? So an echo test, and that's like a 3D echo or a 2D echo of the heart to kind of see what's going on with that. And then BNP levels, that's used to diagnose heart failure. And that got to be elevated just because of that stretching out, right, of the right ventricle. So what are the treatments that we use for cor pulmonale? Well, we want to find the underlying cause. So we want to find a way to treat that COPD that you're getting. So prescription medications that decrease blood pressure and then encourage oxygen flow back into the lungs. Of course, diuretics are good for pulling fluid off. And then continuous low flow oxygen. And we'll talk quite a bit about oxygen here in a few minutes, but you're already probably familiar with it just from your previous semester and even in practice. All right, so that was it for cor pulmonale. So what about COPD exacerbation? So, and that happens a lot. That's actually what people get admitted for, is just a COPD exacerbation. And that's just a sudden worsening of their symptoms, right? That lasts for several days. Most times COPD patients are fine to be at home. They're out in the world. Maybe they're carrying their oxygen tanks around if they need them. But, it doesn't always, you don't always have to be admitted for COPD. But an exacerbation, yeah. When you start getting these exacerbations, you start looking at poorer outcomes. The disease is progressing to the point where people are struggling more and more. So signaled by a change in their usual dyspnea, shortness of breath, maybe their cough is changing, they're producing more sputum, or that sputum that they are producing is purulent, right, or pussy and bacteria laden. So some of the primary causes, again, are bacteria or viral infections, so this might be something that people that with flu, pneumonia, and even the dreaded COVID-19, right? So some of those signs that it's getting worse, using your accessory muscles more and more, and you get that central cyanosis. So central cyanosis just means they overall have this almost kind of a blue tinge to them, right? And not blue like a Smurf blue, even though that would be kind of cool. But anyway, we'll stay away from Smurfs. But they do get that tinge. So the treatment for COPD exacerbations are those short-acting bronchodilators, right? So those are the inhalers that kind of help open up those airways. Maybe they're going to get corticosteroids, right? Usually in pill form. So again, antibiotics. Use of antibiotics is a little controversial because we're not necessarily sure they have an infection, right? But if they do end up showing up with a green or purulent sputum, that might indicate that, maybe we need to get some antibiotics, and then maybe we need to increase the amount of supplemental oxygen that they're getting. So that was the COPD exacerbation. So what about respiratory failure? So respiratory failure can be caused by a few different things. So one of them might be the exacerbations that we just talked about. So they wait too long to come to the hospital. Again, they either might associate it with, well, I'm just more tired, I'm getting older, and so they wait too long to come to the hospital or to contact their physician. They stop taking their medications, either their bronchodilators or their corticosteroids. Either they don't like the effects, maybe they can't afford them, or for whatever reason, they end up not taking them anymore. And so they develop an exacerbation, which then brings on respiratory failure. Maybe they're an overuse of sedatives, benzos, or opioids. And every once in a while, that's us doing it to them. So we don't realize how bad their COPD is And maybe we're giving them some medications to help them relax or to deal with their pain. And these people just can't deal with it. And so that's often that pre-op or post-op situation. Maybe surgery or severe painful illnesses involving the chest or the abdomen. Again, these things are affecting how effective their respiratory drive is, right? So because these things might be happening, it hurts to breathe or hurts to take a deep breath before they develop pneumonia. They have that ineffective ventilation that's happening. So with acute respiratory failure, this is a typical, respiratory failure patient. That's, actually this guy looks like they're pretty sick. You can see the ventilator here. We start out usually trying to do a BiPAP or a CPAP for their first line, but usually we end up having to intubate them with the ventilator support. So BiPAP, in case you're not BiPAP or CPAP, that's biphasic, so that's helping air move in or out. So it's altering how much pressure the machine is supplying to the patient. CPAP is just a continuous, the pressure is the same. Really what we're trying to do is keep those airways open with that positive pressure, right? Continuous positive airway, right? So, and again, we talked a little bit about trachs in the last week or so. You guys did it in a skills lab. But if someone gets intubated, we end up after 7 or 10 days, if we can't get them extubated, then we have to go ahead and trach them. And I think I put in some stuff. So, and the reason for it is, see, this is an ET tube here. So an ET endotracheal. So it goes through the mouth. This is the pilot balloon tongue. And that's that cuff, right? And we inflate that cuff so that we can make a seal. And again, because that's pushing constant pressure on the trachea, eventually that tissue will start to break down, and then we'll never be able to, tissue dies, and that's not good for anybody, it turns out. You can see that the balloon is down, so it goes through the vocal cords, right? So also, that's the other thing, is damaging their vocal cords because that tube is constantly going through it, and then here's the esophagus behind. I put a picture of an ET tube here next, just so you can see what one looks like outside the body. This is the kind that we use most often anymore. They go by sizes, 6.5 up to 8.5, and that's all. It's measuring. This is an 8.5, and that's the lumen that's in the center, right? So this is the part that's going down into the body. Here's the pilot balloon, and that's going to inflate this cuff. There's also, you can't see it on this picture here, but there's a little hole here because people are still making oral secretions, right? They're still producing saliva and that kind of thing. And so what happens is it goes through and it comes through and it tends to collect right here. Well, eventually it can seep past this balloon here, get down into the lungs, and then develop what's called ventilator-associated pneumonia. So they have this little suction device. This is that secondary suction, and it's usually an intermittent suction. And so it kind of keeps that suction pulled away so that fluid or that saliva doesn't sit here, start making bacteria. And then, of course, there's the airway. So that's an ET tube. Hope you never need one. All right, so next complication, the last one we're going to talk about is the depression and the anxiety that these people have. This is kind of a condition that, it's really hard on them psychologically and emotionally, right? They're experiencing, I talk about many losses, right? Oh, they can't do the things they used to do. Think about how active you are right now that you're out. You don't think anything about jumping up and running out. Well, not the last few weeks, but typically you're going to jump up out and you're going to go out and about and not have any issues, right? All of a sudden, these people, they're either homebound or they're constantly have to drag an oxygen tank around or something like that. And it's really depressing. So we have to maybe talk to them about how they're feeling and they either use that therapeutic communication to kind of let them deal with what's going on, right? How are they doing with their ADLs, right? Are they able to cook for themselves, do their own laundry? Or are they becoming more and more dependent on their family, right? And speaking of which, how's the family coping with that? So it's hard on everybody with these patients, especially as this disease progressive. progresses. So some of the medications that can help, this is a Buspar. The thing about Buspar is it kind of helps with anxiety, but it has very few, if any, respiratory depression effects. So you'll see this a lot in COPD patients or anybody that's having trouble breathing. But if they do become anxious because of dyspnea, and this happens, so you teach them that pursed lip breathing. So and the way we teach pursed lip breathing, of course I'm not there, so I can't really just show you, but you take a deep breath and you kind of almost like you're going to whistle, and you're barely letting any air out. And if you try that, if you practice it yourself, you'll realize how you can feel the pressure building up in your lungs. So you're doing a couple of things. You're keeping that pressure up. You're also extending that IE ratio, right? You're extending how long it takes you to exhale. And hopefully by taking more time to exhale, you're able to clear more oxygen, or actually you're exhaling CO2 so that you can now start getting more oxygen in. So COPD interprofessional care. Well, sorry, that's stable COPD. Oftentimes, I said earlier, they're treated as outpatients, right? So they're able to live and work, and just depending on how bad it gets. We do always want to have them get their flu vaccine or their pneumonia vaccine. I don't know if I'm going to talk about, I think I do talk about pneumonia vaccines, but there's a couple of different kinds. And if they get these acute exacerbations or acute respiratory failure, they end up getting admitted to hospitalization, probably into the ICU. So some of the medications that we might use are bronchodilators. So I'm going to encourage you to kind of be a little bit familiar with these. You don't need to be too crazy about it, but kind of know a little bit about these. These bronchodilators, it's a good idea if you can encourage people to take those before they are going to exercise. And exercise, I don't mean doing jumping jacks or running around playing tennis all day, but even before they're doing anything that's going to have them increase their oxygen requirement. So we usually get them to take a bronchodilator. And it helps improve the ventilation of the lungs, and the inhaled route is preferred. The thing to remember also about bronchodilators is they tend to increase heart rate. So they have that relationship. So you have a patient that's already, their heart rate's 130, 135, something like that. Maybe a bronchodilator may not be what they need. So some of the commonly used bronchodilators are those beta-2 androgenetic antagonist duonebs. And you'll hear about this all the time with patients that are getting these duonebs in the hospital. They're getting breathing treatments. But then the anticholinergics like Advair, or a combination of Advair and Spiriva. But what I want you to remember about those, if you would, how do you administer those? How do people use them? What precautions do they have to do? Do they have to rinse their mouth out, yes or no? So I'll let you kind of look that up. Don't ask me. Going on with in those COPD patients that have patients that have that FEV1 less than 60, maybe they're going to do a long-acting anticholinergic, and that's LABAs, and that's Ceravent. Also, maybe some inhaled corticosteroids like Pulmicort, Symbicort, Flovent. And then the antibiotic therapy that we usually use is azithromycin, and I think they're talking about that in relation with hydrochloroquine, or what is that for COVID-19, and that's a Z-Pack, a lot of times is what that's referred to as. So the interprofessional care, well, oxygen therapy, let's keep their sats greater than 90. I'm sure you've heard that maybe it's 88, and that might be the order that you get. Sometimes the order will be to say, maintain the saturation between 88 and 92. Just keep in mind that while that is true for a lot, but it's not true for all, right? Remember, there's no such thing as always and never in nursing or even healthcare. So, but we do want to keep their sats greater than 90% during rest, sleep, and exertion, or their PaO2 greater than 60, and you're not going to be measuring that. So just be aware that that's a secondary measurement. So why do we get them on this oxygen, right? So not everyone's excited about being on oxygen. They say, well, I don't want to. Well, first of all, it improves their survivability. They're able to exercise more, then be more active. It helps them with their cognitive performance, right? So not only do they become less confused, but their brain function kind of helps out. And it helps them get a good night's sleep, right? It improved their ADLs and their basic quality of life. All right, so let's talk about some oxygen delivery systems. I'm going to go through this quickly because you probably got this not only maybe in your, I don't know about pathophys, but you probably for sure got it in first semester. And those of you that are LPNs, I'm sure you're dealing with this on a regular basis too. So there's high flow and low flow, right? Low flow is the most common, right? Low flow, it mixed with room air. The delivery is less precise, right? So that when we think about that, think nasal cannula, non-rebreathers, and simple mask, right? They're a combination of that oxygen along with regular air. So high flow examples are a Venturi mask, heated high flow nasal cannula, and that's what that is right here. So this is heated and humidified air. And then a trach mask, we saw those when we did trachs. Venturi mask, this right here is where they can adjust the percentage of air. So this isn't, when you're seeing these before, like with these, remember we go by liters, right? They're 2 liters, 4 liters, 6 liters on a nasal cannula or on a non-rebreather. But for these, this is going to go by a percentage, 30%, 40%, 50% oxygen. Same thing with this. This is more blow-by, so maybe not as accurate just because of the air that's getting mixed in there too. And this is something that, there's humidified. The thing about this, between this and a nasal cannula, the prongs on a nasal cannula are fairly small. And so patient might have, there's only so much oxygen that we can get for them. And that's 6 liters on a nasal cannula, right? This thing can go up to 15 liters. So for people that need a higher oxygen requirement. We always want to humidify. Oxygen is very drying, especially when it comes out. That's why we don't see a bunch of rusted tanks hanging around. So the humidification maybe is going to be supplied by nebulizers, either a vapotherm or even bubble through humidifiers. This is what you see most often when somebody's on a nasal cannula. The oxygen is hooked up to this, and this thing is in there, and the water's in there bubbling away. And this is what a vapotherm looks like. So not commonly seen, but you'll for sure see it. But it's not going to be, you see this all the time. This, maybe not so much. So let's talk about some of the complications of oxygen therapy, right? A lot of people don't understand this. Had a big debate one time with one of the physicians at Northwest about, is oxygen combustible? I will tell you, I don't want to brag, but a little bit. I won. Oxygen itself is not combustible, right? It's necessary for combustion, but oxygen itself is not combustible. So there's that combustion, and people don't realize what's happening is, what happens is that oxygen that they're taking at home, it permeates everything from their clothing to any fabrics, their couch, their drapes, their rugs, becomes saturated with oxygen. And what oxygen does do, while it's not flammable itself, because of a high oxygen content, once it gets a spark, so it's got a heat, it's got fuel, and it's got oxygen, it burns hotter and faster. So people need to understand that that's not something to mess around with. Keep smoking and open flames out of the place. I think somebody asked me one time, does that mean you can't have a gas stove? And honestly, I don't know about that, but I would say if you could avoid it, you probably want to. And maybe the big thing is just keep that spark away. If you're going to have a gas stove, don't have those oxygen saturated things around, right? So don't do your cooking in the living room, right? So that sounds like a good idea. So CO2 narcosis, that happens a lot with COPD patients, right? These people are used to having a high CO2 count, right? Remember, they're retaining all that air. They can't exchange it out. So they typically have a high CO2, and that's what drives their respiratory effort, right? So for us, typically, we sense, for non-COPD patients, we get a buildup in CO2 in our bloodstream, and our body tells us to, hey, breathe more, right? To get rid of that. Well, these people are constantly high. So what's happening for them is their respiratory drive is driven by a lack of oxygen. Well, if we start giving them a lot of oxygen, it actually suppresses their respiratory drive. And that's why you see those orders that say, keep their saturation between 88 and 92. You don't want them to get too high because they'll stop breathing on you. So O2 toxicity due to the prolonged exposure of high O2. So what happens is that prolonged exposure to high levels of oxygen, so they stop breathing. Absorption atelectasis, that's just those high concentrations of oxygen that you're putting into their lungs. It actually washes out the nitrogen. So typical atmosphere, what you're breathing in is 21%. Room air is 21% oxygen, but it's 78% nitrogen. So when you wash that nitrogen out, you get all of a sudden your alveoli start to collapse. So that's what they mean by absorption atelectasis. You can also get infections just because of the nebulizers, or maybe their CPAP machine or something like that. Maybe not keeping it as clean as they should be. And so bacteria gets in there, and now you're breathing bacteria. It's getting just pumped into your lungs. So long-term oxygen therapy improves the good prognosis, mental status, exercise intolerance. But they need to get checked every now and then, right? You can't just say, well, I'm going to go home on 2 liters of oxygen or 4 liters of oxygen or whatever it is. It needs to be reevaluated on a regular basis because your body changes, right? You might need more, you might need less. So let's talk about some of the things that that can maybe help them out. So respiratory therapy, breathing retraining. We talked about the pursed lip breathing, or then diaphragmatic breathing. The way I always teach people to do the diaphragmatic breathing, and that's that abdominal breathing, is either have them, I usually would do this with you in class, but have you're sitting there and put one hand on your chest and then one hand on your abdomen. And what you want to do is have them breathe in slowly so that their stomach rises and not their chest, right? So, and by putting a hand on each one, you can kind of teach them to do that diaphragmatic breathing, which is a more effective way of breathing. Teaching them how to have an effective cough, right? Taking a good deep breath and forcefully coughing. There's some airway clearance devices that provide a positive expiratory pressure. We'll talk about them. They produce vibrations. What they do is that those vibrations actually kind of shake that mucus loose inside the lungs so that it's easier for them to get out. A couple of devices that we see most often are the flutter and the acapella. And we'll talk about both of those. So this is the flutter valve. This one I'm circling right here. The thing about a flutter valve is you only blow on it, right? And you see sometimes people will inhale it. This is not like an ascending spirometer. But this, they're blowing out on it, but they have to sit upright, right? It has to be sitting up. And the angle that this thing is also important. This is designed to be horizontal. So this is almost looks like one of the pipes that your grandfather had. Maybe you're not, but anyway, that's kind of what that's designed to do, right? And again, there's a ball bearing in there that as they blow on it, it sets up the vibrations down inside their lungs. And that helps be able to mobilize those secretions. This one is called an acapella. I would like to say you always see these on a bedside table or in a patient's hand, but honestly, a lot of times they're by the sink, they're on the counter, they're in the windowsill. Same thing for both of those. I don't know why people don't do it. Maybe they do it for a while and it's just got away from them. I don't know. The thing about this is you can inhale or exhale on it, right? And you can be in any position. So you can be lying down maybe 20, 30 degrees, lying in bed and working with this thing. And it's just as effective. So this one, upright, blow only. This one, any position, in or out. So there's also this chest physiotherapy. This is a physiotherapy vest that we kind of do now. But back in the day, what we would do is you would actually take either your cupped hands or the mask from a bag valve mask and have a patient sit forward and you just start pounding on their back, right? You're trying to use just physical force to loosen up that mucus that's in there. So the percussion and vibration, and it helps out with that postural drainage. Right? Thankfully, we got some really good respiratory therapists that kind of come and do that for us. Some of the beds that we use in the ICU, I don't know about Banner, but definitely at Northwest, you can just, the bed just shakes the whole patient, right? So for nutritional therapy, again, we talked about how, these people, eating isn't always as big a deal as it should be. So they get malnourished, and there's for a couple of different reasons. So they have an increase in their inflammatory mediators that we talked about earlier. They have an increase in their metabolic rate. That's just because their work of breathing is high, right? They're constantly working to breathe. Well, they're burning more calories, right? So they also get a lack of appetite, and that's for a couple of different reasons. One of them is as they eat, they can't breathe. And so they just go, eating becomes a chore. And so they just don't do it. The other thing that happens is their taste buds get altered, right? So that chronic mouth breathing that's happening, all of a sudden, food doesn't taste as good. And when they're having this, this is it's kind of a weight loss is kind of a predictor that maybe the outcome's not going to be as good as you might want it to be. So again, keep going with interprofessional care. So we want to decrease dyspnea and conserve energy by having them rest 30 minutes before they eat. Maybe use a bronchodilator, and then don't exercise before or after eating. Just let your food digest. Make sure you're rested so that you can. If your patient is wearing a mask or even a CPAP or a BiPAP, you can maybe put them on a nasal cannula just long enough for them to eat, so as you're not trying to maneuver a fork with food and moving the mask, taking a bite, putting the mask back. Sometimes it's just too much for some people. I don't know if I could pat my head and rub my tummy at the same time either. So maybe look at that, for that 15 minutes that they're having dinner or breakfast or lunch. Maybe you can put them on a nasal cannula. Just keep an eye on their SATs, that supplemental O2. So we want them to eat high calorie, high protein diet. And again, 5 or 6 small meals to avoid that bloating. They get satisfied easier. But anyway, and again, those smaller amounts that have that. We want to have them avoid the foods that take a lot of chewing, right? So maybe well done steaks, not a good choice for them. Maybe softer foods, mashed potatoes, meatloaf is a good one. I'm just throwing stuff out there. So there's also some surgeries that are done, right? Just so you're aware. So I'm not going to ask you about any of these, but I do want you to kind of know that they're there. I don't think I'm going to ask you. Stay tuned. So a lung volume reduction surgery. So they remove that diseased part of the lung, and so that the remaining parts are able to work more. They get more of the blood supply. They get more of the oxygen supply. So that also kind of allows the diaphragm to return to that more rounded position, right? They remove part of that. Now there's more room for the diaphragm, and it can work better. They do a bronchoscopic lung volume reduction surgery, and that's where they place these one-way valves down in the lungs, right? So they help air go out, but they kind of reduce the amount of air that's going in, right? Remember we talked about what's happening is these patients have a lot of air that's built up in their lungs and they can't get it out. There's also a bulectomy. So bullae, as I write here, they're simply large air sacs that form from the destroyed alveoli. So the walls break down, and now you have these big pockets of, they're just holding air, right? So by getting rid of them, you can improve lung function. And then finally, if it gets bad enough, maybe a lung transplant. Either one or both. All right. So this is one of those bronchoscopic lung volumes. So this is altering the way the air, as you can see here, it is. It's in place in the airway, and here it is when it's being placed, right? And this is blebs. So air-containing bleb. This is a plural in the plural space. And so what they might do is they go in and they try to remove those. And then also this is where this is a big bleb right here. They're just cutting it out. You can see they kind of have it clamped off here and they're going to remove it. So some of those gerontological considerations. So as people age, So lean body mass is reduced, so they have less muscle strength. So now they're working harder to breathe, but they don't have the muscles to do it with. So again, increased dyspnea, and again, exercise becomes more difficult. And it's also complicated by those comorbidities that you might have as you develop. So either cardiovascular disease, osteoporosis, impaired cognition, or even lung cancer. So nursing diagnoses, pick your favorite. So what are the goals that we're trying to get to? Well, we would like to prevent the disease from progressing, right? We would like it to stay where it is. And it is going to progress, but maybe we can slow that down, or even if we can't prevent it. Have them be able to perform their ADLs. They can do their own laundry. They can cook for themselves. They can get their own mail. Relief from the symptoms being, we talked about several of those, either, anorexia, or dyspnea. They have to sleep sitting up almost, and then again, none of those COPD related complications that we talked about, core pulmonale, respiratory failure, and exacerbations. So health promotion, we want them to abstain from or stop smoking altogether. Avoid or control exposure to pollutants and irritants, and that might be easier said than done just because of where they live and who they live with. And then early detection and treatment of any respiratory tract infections. So these people need to be hyper aware of what's going on. And if they feel like they're starting to develop a respiratory tract infection, they need to get in to see their physician sooner rather than later. And we want to make sure that they understand that. So acute care would be required, of course, for an exacerbation if they develop pneumonia, core pulmonale. The degree of severity of the underlying respiratory problem kind of needs to be assessed, and where we're going to go from there. So maybe not acute care, but that ambulatory care. So pulmonary rehabilitation, making sure they understand how to take care of their lungs. Activity considerations, make sure you're encouraging them to kind of exercise for a few minutes and then rest, right? So shortness of breath, that's a normal thing for when you're exercising, right? And it's the same for them. Just because they get a little short of breath, I mean, not to the point where they collapse or pass out, but, that doesn't mean you should stop. It means that you're exercising, and that's going to help you get better and better. So maybe sexual activity again, hey, whatever works for you. Let your ability to breathe be your guide, right? Sleep. Do you need oxygen to sleep? Do you maybe need to sleep with pillows, elevate the head of the bed? Some people sleep in recliners. We would hope that's not the case, but it might be. The psychosocial considerations, healthy coping, that's kind of a challenge for these people. Oftentimes they feel guilty, because they haven't maybe taken care of their body. They've smoked for all these years, and now they're kind of beating themselves up. I did it to myself. I don't deserve to be cared for. They feel guilty. They're depressed. They're anxious. Maybe they're lonely. They can't find anybody. They get divorced, or spouses passed away, or something like that, and they get frustrated. So, when is this ever going to end? One of the sad things is, there's those end-of-life considerations that you kind of have to think about. So symptoms can be managed, but COPD, there's no cure for COPD, right? End-of-life issues and advanced directives that we sometimes, physicians usually are the ones that are going to have this conversation with patients about whether or not they're full code or maybe they're DNR or DNI, do not intubate. But they're going to talk with the physician, and that conversation is going to take just a couple of minutes. And what's going to happen is it's going to be you that's going to be in there talking with them, and having them understand that, there are many options, right? So that palliative end-of-life care, that at least they understand what it is. Hospice doesn't mean that we're going to pull the plug on you and then whatever happens to you happens to you. You still get treatment, but they will do all they can to make you comfortable for in those kinds of situations. So what are the expected outcomes that we'd like to get to? Well, return to their baseline respiratory function. And notice I say baseline, right? They're never going to be back to where they were or you were when you were 18 or 19, right? But whatever their baseline is, demonstrate an effective rate, rhythm, and depth of respirations, having clear breath sounds, maintaining their clear airways, and their CO2 and PaO2 levels return to normal for that particular patient. Again, our expected outcomes, you can't read this, I'll post this thing. The awareness of when do you need to seek medical attention, right? So when do they need to call 911, when do they need to call their doctor, and when do they need to just kind of relax a little bit? So behaviors minimizing the risk of infection, maybe being careful of what they're being exposed to. Like we think about it right now with this COVID-19. These people definitely don't want to be out going to the grocery store, right? So, and we want to make sure they're keeping all these infections away from them. So I put this up here, COPD with chronic bronchitis. But again, don't think that these are mutually exclusive, right? You can have one and not the other. But typically, we call these the blue bloaters, right? Because they have that excess mucus production in the bronchioles, right? So now they're hypoxic and hypercapnic, so low oxygen, high CO2. And that's due to usually the mucus plugs that's in the airways, right? So they get that, again, that increase in the CO2 level and then a decrease in the O2, right? So they get that cyanosis, and they call them the blue bloaters. The other condition that might happen is emphysema. Emphysema is not always, again, you can have one and not the other. But this is usually happening with that barrel-chested breathing, So smoking inhaled chemicals cause a decrease in the elastin and the collagen in the lungs. And so you get a decrease in the pressure. So the airway sucks inward. Healthy lungs can't withstand that lower pressure, so they don't collapse, right? But that's with a healthy lung, right? These people don't have healthy lungs. So it causes those airways to collapse. Now you get air trapping in the alveoli, which are getting larger and larger just because more and more pressure. Think about a balloon that's being blown up. So airways are more compliant, and they get larger, reduces the surface area for gas exchange. And they're dyspneic all the time, right? They're constantly having trouble breathing. That pursed lip breathing is really what's going to help them. And we call them the pink puffers, right? Again, they're kind of have that pink color just due to the increase in the hemoglobin that's in their body, and plus they're puffing away, right? And then because they can't see the pictures very good, here's the cartoons that I stole. Okay, so let's talk about lung cancer. It can be a devastating disease. It's the leading cause of cancer deaths in the United States. So 28% of all cancer deaths are lung cancer. So 250,000 new cases every year in the United States, right? It has a very high mortality rate. It's improving. It's getting better. They get better and better with treatments. But still, it has a very high mortality rate. So, and both smokers and non-smokers can develop lung cancer. So you can never be near smoke in your whole life, and you can still develop lung cancer. And conversely, I almost kind of hate to see this. Sometimes you see somebody, they're 102 years old, smoking a pack a day, and don't have a lick of cancer. So kind of a bad advertisement. People always I think sometimes people kind of go, well, they always, smokers forever know this story, right? They can always tell you about somebody that's been living forever, smoking every day, and never got cancer, and they hope that's going to be them as well. So what's the pathophysiology? Well, cancer arises from mutated epithelial cells, right? And that tumor development gets promoted by the epidermal growth factor. It's very slow at first. It takes 8 to 10 years for a tumor just to reach 1 centimeter, which is the smallest thing that can be picked up on a chest x-ray. And usually that's the thing that gets it first, right? You see a chest x-ray, and they might see a spot on your lungs or something, and they go, oh, hey. And by the time it's big enough to be seen, the disease is probably somewhat advanced, right? Occurs primarily in the segmental bronchi or in the upper lobes of the lungs. So the screening. So we start screening annually in adults ages 55 to 80 when they have a history of smoking, or someone's 30 years of smoking at a pack a day, right? So they've got a 30-pack year history, or they currently smoke, or they quit smoking less than 15 years ago. This gets completed with a low-dose CT, right? So they might suspect that they might see a spot on an x-ray. They talk to the patient, determine are any of these factors going on. Then you might go ahead and do a CT, kind of see what's going on, see if you can find it. So smoking is the most important risk factor in 80 to 90% of all lung cancers. Tobacco smoke itself contains 60 carcinogens, right? And which always can say, hey, as an ex-smoker, I'm probably maybe one of the worst ones to talk about it. But I mean, people know this. They know that there's all these carcinogens that are in cigarette smoke, and they continue to smoke anyway. I think that just kind of speaks to the how addictive cigarette smoking or cigarettes have become. And so that it causes a change in that bronchial epithelium. Well, if you can get people to quit smoking, you can really greatly reduce their risk. So the risk of lung cancer gradually decreases with smoking cessation, reaching that of a non-smoker. So 15 years after you quit smoking, your lungs are just as healthy as if you had never smoked. So, that's something that most people don't understand. So maybe by educating people, they can maybe get them to quit. They might feel like they're too far gone. Hey, you're not too far gone. So the risk related to the total exposure. So how many cigarettes were smoked? How old were you when you started? How deeply do you inhale the tar and nicotine content? And the use of unfiltered cigarettes. My father always smoked these unfiltered cigarettes. He was constantly picking tobacco out of his teeth. And I was like, Dad, so gross. Keeping in mind, though, secondary smoke contains the exact same carcinogens as mainstream or primary smoking. So other carcinogens can bring that on. Pollution, radiation, asbestos. Asbestos was a huge thing. It was back in the 40s and 50s. It was a construction material. It was in people's walls and their insulation, in their floor tiles. They found out that it was a carcinogen, and so they've kind of outlawed its use. I want to say that the current administration, they're kind of looking at they're saying, well, maybe we can use asbestos in some things. Maybe asbestos is really not that bad, but well, I don't know. Seems pretty bad. Causes cancer. Significant variation in the likelihood, kind of based on gender, genes, hormones, or the molecular influences. You can go into Lewis on page 514 and get more information about that. So, primary lung cancer is categorized in two subtypes. I always think this is kind of crazy. So we have the small cell lung cancer, or SCLC, and that's 20% of the cancers. And because we're so clever in the way we name things, we have the small cell. We don't have medium or large or big or giant. They're not small, they're non-small. So it always kind of cracks me up when I see that. So we'll look at non-small cell lung cancer first, right? So squamous cell carcinomas, they're slow growing. They usually have early symptoms, right? Then there's adenocarcinomas. That's 30 to almost 50% of all lung cancers. They're moderate going, and it's the most common one that most non-smokers get. And then there's large cell carcinomas, right? Again, non-small cell. Now we have the large cells. Rapid growing, and they're highly metastatic. And metastatic, as you probably know, where it spreads and it grows to other organs or other parts of the body. So for the small cell lung cancer, that's only 20%. However, it's probably the most dangerous, right? Very rapid growth. It's the most malignant. It metastasizes real easily, real early, and through the lymphatic system and the bloodstream. Frequently, it's going to metastasize to the brain, right? And that kind of makes sense, right? So lungs, one of the first things your oxygen and blood goes, your body always wants to make sure that the brain is supplied first. So that small cell lung cancer that's metastasizing usually gets to the brain first. A lot of times associated with endocrine disorders. Chemotherapy is the main treatment for this. There's some radiation, some adjuvant and palliative things, but again, a very poor prognosis for the small cell. So lung cancer metastasizes usually either by direct extension, which means it grows from one cell to the next, and so it goes from one cell to the next cell to the next cell to the next organ system to the next tissue, right? So that's direct extension, right? It also can go through the lymph nodes, right? To the liver, the brain, again, most frequently first, bones, as well as the adrenal glands. And there's parental-plastic syndrome. You don't have to memorize this, just kind of be aware. I don't know if it's even ever going to come up again in the program, but it might come up on NCLEX or something. But a set of signs and symptoms that's a consequence of cancer in the body. Usually it's caused by the tumor cell, the secretions that the tumor cell is letting go of, either hormones, cytokines, enzymes, and of course antibodies. Those manifestations of symptoms before the malignancy is even diagnosed, right? So people that have this hypercalcemia, SIADH, or syndrome of inappropriate diuretic hormone, Cushing's, polycythemia are just a few of them. Of course, there are more. Also, you get a loss of muscle tone, right? Muscle loss, slurred speech are the things you might start to see before you even ever get diagnosed with cancer. So symptoms a lot of times are non-specific, right? And they appear late. So that's why sometimes you get that chronic cough and you might think, oh, I'm smoking, or I have I got the flu or something like that, or I've always had this cough, when that's kind of those non-specific manifestations. And it kind of depends on the type of the primary, small cell, non-small cell, where it's located, and how much it has spread or metastasized. So what are some of those clinical manifestations that you might see? Well, pneumonitis, right? Lobular pneumonia that doesn't respond to treatment, right? So they're giving you antibiotics, they can't figure it out, you're not getting any better. Finally, they do some x-rays and some CTs or a PET scan and find it. Maybe a persistent cough that has sputum is probably the most common thing that's seen, hemoptysis, right? So you're coughing up bloody sputum, dyspnea, wheezing, chest pain. And so chest pain, I think we all frequently kind of go chest pain, and we always think heart, but most often, or maybe I don't know about most often, but frequently, I should say, it's not the heart, right? It's the lungs or something else going on with that. And it can be localized or unilateral. Unilateral, I mean, it's occurring on both sides of the chest. So some of the later manifestations, anorexia, fatigue, weight loss, nausea, vomiting, intrathoracic spread and malignancy, unilateral paralysis of the diaphragm. So all of a sudden you're having trouble breathing. Remember, the diaphragm is what's responsible for helping you breathe. Superior vena cava obstructions, palpable lymph nodes. That's like when you go to the doctor, maybe you're checking on yourself, and they're palpating your neck up underneath your jawline. They're looking for enlarged lymph nodes, right? There's also mediastinal involvement. And so by that, it can lead to like either pericardial effusion, which can then lead to cardiac tamponade, or because of that enlargement of the heart, you all of a sudden you start to get dysrhythmias. Right? And sometimes that's the main thing that you see. So the diagnostic studies, again, we talked about a chest x-ray is usually the initial thing that kind of gets it started, right? They see a spot on your chest x-ray, and so they go and they do a CT scan. And that kind of to identify the location, the extent of the mass, but they've got to do a lung biopsy for a definitive diagnosis, not only of is it cancer, but what type of cancer. They can do analysis of the pleural fluid by doing the thoracentesis, in case they don't want to actually pull tissue. So lung cancer diagnostic studies. So there's bone scans, CT of the brain, pelvis, abdomen, of course CBC, chemistry panel, MRI. PET scans are usually used to evaluate and stage how far along the cancer is. So speaking of staging, so there's a couple different ways. So for the non-small cell staging is according to the TNM system. So the T denotes the tumor size, location, and degree of invasion into other areas. The N indicates whether it's regional lymph nodes are involved, and the M represents the presence or the absence of any distant metastases. So you can look at table 15.5, I think is where you might find some more information on that. And then here's the staging. Again, I'm not going to ask you to stage cancer, but just be aware that there are different stages, and not only there are different stages, but then there's A's and B's in there as well. So for small cell lung cancer, that TNM is not particularly useful, right? It's an aggressive cancer it's almost always considered that it's systemic, right? Then it's also staged as either limited or extensive. And by limited, I mean it's confined maybe to one side of the chest or maybe one region of the chest. Or if it's extended, it's spread beyond that limited stage, right? And most small cell lung cancers are extensive at the time they even get diagnosed, right? Just because of the nature of it. So treatment of choice for early non-small cell lung cancer. So maybe a pneumonectomy where they're going to remove an entire lung, maybe a lobectomy where they remove just one or more lobes of a lung. There's also something called VATS, right? So video-assisted thoracoscopic surgery. You can see this person has had lung surgery, and honestly, you can't tell was it a pneumonectomy or a lobectomy, but that's usually where the scar shows up. So again, not indicated for small cell. Remember, small cell, just due to the fact that it's spread so far, usually chemo and radiation are the choices for that. And I think we'll go into that. So here's what a pneumonectomy looks like. So removal of one entire lung, the lobectomy, removal of one or more lobes. They can do segmental or wedge resection. And this is what a VATS looks like. So this is a video-assisted thoracoscopic surgery used to treat the lung cancers near or outside the lung, right? You can see where they're doing that video-assisted. They go in and they might take a portion and remove part of it. Right? So that's what a VATS procedure is, if you hear about that. So what about radiation therapy? I mean, that's one of the things that's frequently being used. So that's a treatment for both non-small cell as well as small cell lung cancers, right? It can be curative, palliative, or adjuvant, right? So it might be used in addition to something else, right? It's a primary therapy for those that can't tolerate surgery, and it might be palliative, right? So maybe they just want to reduce the size of the tumor so that it's a little easier for the patient to breathe, maybe improve their pain, knowing that they're not ever going to really get rid of it altogether. And of course, we want to make sure we're monitoring for the complications. Some of the complications of radiation therapy are esophagitis. Of course, there's skin irritation where the radiation, as their skin tends to break down, they might experience nausea, vomiting, anorexia. There's also something called radiation pneumonitis that we have to make sure we're watching out for. So there's the stereotactic radiotherapy, or SBRT. So that's what that's doing. That's usually only for smaller tumors, right? So it's a high dose of radiation delivered to the tumor, and what happens is several beams are aimed at different angles in order to precisely target the tumor. So it's sending the same beam of radiation from all different angles, all targeting that one small area. So, and then the nice thing about that is it's high dose, but instead of it being in a larger area, it's going to a very small area, right? So only for smaller tumors. Typically done over 2 or 3 days. So also, of course, chemotherapy. Now, chemotherapy is something that you've got to go through special training to give, other than the pill form, but even the pills require special handling. They usually want you to use the double gloves, and then you got to be careful with the package that the pill came in. They usually want you to wrap it up inside one glove and then wrap up that glove inside another glove, just because, well, hey, it's poison, right? So chemo, that's the primary treatment for those small cell lung cancers. Treatment in non-resectable tumors, or maybe it's adjuvant to surgery. variety of protocols for it. Again, if it's going to be IV chemo, you get special treatment. And usually these people are going to go to cancer treatment centers. Sometimes they're in the hospital. Maybe your hospital might have a cancer unit where nurses are specially trained to deal with this. Their waste products have to be dealt with in a certain way. For those of you that might be in childbearing age, there's even a chance you might be pregnant. You want to maybe stay away from somebody that's getting IV chemotherapy. Just tell your charge nurse, hey, I think I'm pregnant. I think I'm trying to get pregnant. There's just a possibility I'm pregnant. And just stay away from it. Have somebody else take care of those patients, right? Don't mess around with that and make your babies be born naked. So targeted therapies to block tumor growth, maybe it's less toxic. There's tyrosine kinase inhibitors. And those are the things that block the signals for the growth. And that's what happens is cancer is rapidly growing cells, right? There's kinase inhibitors, right? And they inhibit that protein that's responsible for that cancer development. Angiogenesis inhibitors, they target the vascular endothelium or that growth factor from that. Just be aware of this. I'm not going to ask you about it. Just be aware. Opdivo targets the PD-1. That's a protein on the T cells and normally keeps these cells from attacking other cells. And it boosts the immune response. So what are some of the other therapies that might happen? Well, prophylactic radiation craniotherapy. Remember we talked about those small cell lung cancers that might tend to metastasize to the brain first. So maybe they're going to do radiation therapy to the brain or the cranium, just prophylactically, right? We don't even see any tumors there yet, but want to make sure they don't develop there, right? Most chemo won't cross the blood-brain barrier, right? So that's why these patients get at an increased risk for metastasis to the brain. So there's bronchoscopic laser therapy to remove those obstructing tumors. And then photodynamic therapy. So early stage lung cancers. So what happens with that is they inject a medication called phototherapy. It's injected IV, and it tends to concentrate itself in tumor cells, usually in the esophagus or the outer layers of the airway. And then about 48 hours later, they go and expose those areas to a laser light via a bronchoscopy, and that causes the cells to die, right? And then there's some necrotic tissue that's left over, and then you go a few days later, they go back and remove all that necrotic tissue again. So that's a PDT. Other therapies you might see are stents, right? So stents, not just renal or cardiac stents. This is a stent that's in the the bronchus. So you can see it's helping keep that airway open, right? So relieving that dyspnea, cough, or respiratory insufficiency. Radiofrequency ablation for for non-small cell lung tumors near the outer edges. They can use that. And that's basically just an electric current that heats up and then destroys the tumor cells. So nursing assessment, assessing the patient and the family's understanding of not only the diagnostic test, because they might hear that, hey, I'm going for a VATS, and they don't really understand what that is. Physicians don't always have the time, or I don't know about patients, but even if they do a great job explaining it, patients need time to process, and physicians, they don't always have the time to sit there for 30 minutes and talk to a patient about it. So maybe helping them understand what those diagnostic tests are and how they're going to do it, helping them understand their diagnosis, right? Hey, I'm all about the positive thinking that, hey, I've got cancer, I'm going to beat this thing, and the power of positive thinking, I'm sure is a real thing. But by the same token, they need to understand that, look, here's what you're really up against, right? And I'm not going to be mean to the patient, but I do want to make sure they understand what's really going on, what the treatment options are, and what's the prognosis for that. Patients have a level of anxiety that might be extremely high, especially with a new diagnosis. And that also kind of depends on what their support system is, right? Maybe they're single, maybe they're not close to their family. And so it may be kind of difficult for them to get that kind of a thing, what might be a death sentence to them. So our nursing assessment, let's look at their past medical history. What's been their exposure to carcinogens, right? Were you a smoker? Is your family smoker? Are you the spouse of someone that's a smoker? Have you been exposed to asbestos or radon? What chronic lung diseases might you have? COPD or TB or something like that? Maybe you have recurrent respiratory infections through your childhood or something. What medications are you using, right? So are you having to use a bunch of cough medicines? Are you going to are you one of those people that goes to Costco to buy the 55-gallon drum of a cough medicine? Well, that indicates that something's probably wrong, right? You shouldn't need that much cough medicine. So what's their smoking history? Calculate their number of pack years. What's the family history of lung cancer, right? There is a hereditary aspect to cancer. Those frequent respiratory infections that I talked about, anorexia, nausea, vomiting, dysphagia, or weight loss, unexplained weight loss. So some of the subjective data might be fatigue, cough, dyspnea, hemoptysis, right? Pain that radiates to the shoulder, chest, arm, or bone, right? Some of the objective data you might find, fever, that parental-plastic syndrome, jaundice, any adventitious lung sounds that shouldn't be there, and then pleural effusions that are happening. Again, more objective data, that pericardial effusion. Dysrhythmias tend to be kind of a late sign as well as muscle wasting. That unsteady gait might indicate that it has metastasized to the brain. And then those pathological fractures. These are fractures that happen for no apparent reason, right? They weren't in an auto accident. They didn't fall off a second story or something. All of a sudden, they broke their arm. And so that's what that is. The diagnostic test results, maybe because of they look at a positive sputum and maybe bronchial washings, and maybe they can kind of look at that materials. So again, here's some nursing diagnosis. You can pick your favorite. So what are our overall goals? Well, an effective breathing pattern. We want them to maintain that adequate airway clearance. Can they protect their own airway? Adequate oxygenation of tissues, a minimal amount of discomfort, right? Cancer is a very painful diagnosis, and so we don't want them to be in chronic pain as much as we can. And do they have a realistic attitude about the treatments and their prognosis? And sometimes that positive attitude is just a great thing. And other times, you might be, I don't want to rain on their parade, but I do want to make sure that they understand what they're up against. So health promotion. Well, God, we must say this. I'll bet every single lecture you ever hear, hey, it turns out smoking's bad for you, right? So knock it off, right? Promote those smoking cessation programs. Make sure they're educated about it. Get them into smoke-free environments. We want to model that healthy behavior by not smoking ourselves, right? I'm sure we go by the hospital and we see, here's the hospital staff. They're out there smoking cigarettes. I don't want to. I encourage you not to judge them. I try not to judge them myself. I mean, it's addictive, right? It's really hard to quit, right? There are some hospitals that deny employment to people that test positive for nicotine. I think that might be kind of going away because I think, there have been enough lawyers involved. Somebody sues them and they go, hey, just because I'm a smoker doesn't mean that. But all they do then is they just triple your health insurance premiums. So the ambulatory care, teaching them the signs and symptoms they need to report, right? So if you suddenly develop hemoptysis, dysphagia, new chest pain, you're getting your voice is getting hoarser. Stay into a smoke-free environment. Careful with that. Make sure they understand about the use of oxygen, what a fire risk it is. Know that constant pain may be a problem. Palliative treatment, and they might need some information about hospice, right? So some of the disability things, the financial planning, what are the community resources that are out there for those that are about to enter hospice or considering entering hospice? In the acute care setting, offer them support for their diagnostic evaluation, right? Monitor for those stressors, right? Do they understand the procedures, the symptoms, and what their emotional needs might be? symptom management, patient teaching, and that's just kind of helping them understand, their diagnosis, their tests, and what's going on with that. Monitoring for those side effects, of that hemoptysis, or maybe they're not able to eat. Do we need to worry about something else? And helping them get access to resources. Case managers and social workers are some of the primary sources for that. And then finally, what are the expected outcomes? Well, we would like to have them have an adequate breathing pattern, an adequate oxygenation, no pain if we can, or at least minimize the amount of pain, and have them be able to talk about their feelings openly and honestly. Because it's a tough diagnosis. I can see where it's very difficult for some people. I think that might be my last slide. I'm going to